go. The project I'm presenting to you today is titled Reducing Avoidable Hospital Admissions for Chemotherapy at the Wollongong Hospital. In 2013, Illawarra Shoalhaven Local Health District attended a world-leading implementation of Mosaic Oncology Information System for the referral, prescribing and treatment of chemotherapy in the inpatient setting. This provided a platform for optimal patient pathway management at all levels of care coordination, seamlessly connecting our inpatients and our outpatient settings. It was later in 2013 that we were fortunate to have presented this implementation here to the Cancer Institute at the Innovation Conference with the aim of improving patient safety, and that we did by standardising our referrals, prescribing and treatment processes, and basically reducing the variation in treatment. And as a result, Wollongong Hospital has proven it's possible to introduce an oncology information system to the inpatient setting, resulting in significant improvements in patient safety. So we've now, as we've standardised our approach to cancer care, we're able to monitor our processes, capture information and use the data to improve our practice. Nope. Sorry, I pressed something. Yeah, I'll stand here. But it was the second element of this outcome that we put under the microscope. Improved efficiency in communication for health professionals. We're able to explore the workings of all our departments. We now have access to information throughout our cancer service, information that was otherwise lost on paper record, filed away, stored on a desk. So how could we use this information? So we embarked on a new project, the aim being to use this doorway to improve patient satisfaction, reduce hospital incurred drug costs, and create bed capacity through a better managed system of coordinated care, one that avoids the planned inpatient admissions for chemotherapy treatment using the oncology information system. So the expansion of the OIS enabled improved management of coordination of patient referrals throughout the service. Before the expansion, chemotherapy referrals were very siloed to either the inpatient or the outpatient settings. There was very poor communication between the locations. This resulted in avoidable admissions to the inpatient setting. These parallel systems for management and triage were resulting in ineffective resource management across our service. An improved outpatient service has the ability to increase overall efficiency of care and alleviate pressure on hospital resources. The increasing number of patients noted to be admitted to the inpatient unit to have outpatient appropriate chemotherapy, alongside an increasing service activity and finite inpatient resources, it demanded that efficiencies in our service provision were identified. So our method began with revising the admission referrals. A process mapping exercise of service-wide chemotherapy referrals was attended with key clinicians and administrators, and the exercise reviewed the admission trends, related drug costs and referral pathways across our service. The data was collated on the chemotherapy that was administered on the ward, and it was categorising between the inpatient and the outpatient regimens, and we mainly used pharmacy to collect this data as we didn't really have those resources available to do that ourselves. In the picture you see there is an indication of that siloed effect of the patient management. Once it was identified there was no space existing in the outpatient setting, a faxed referral would be sent up to the ward and placed in that actual green folder. Once that piece of paper was there, it would only be seen by those performing management duties on the ward, so maybe the nurse manager or the coordinator for the day. And then the patient was effectively lost to the outpatient setting. They could no longer track the movement or monitor for potential vacancies for that patient again. Here is an actual admission referral, and as you can see it's fairly limited information. If you have a close look at the allergies to oral antibiotics, so it's quite ambiguous. You don't really get much from that. The increasing occasions of service across the district emphasised the need for a coordinated and official referral process. So if this process remained inefficient, the impact on our increasing outpatient occasions of service would result in further inpatient admissions, which was which was the natural trend at the time. So an analysis of the admissions for chemotherapy demonstrated that a significant proportion, otherwise 73%, were potentially treatable in the outpatient setting. There are a number of reasons for delivering outpatient regimens in the inpatient setting, so there may be unwell patients, complicated new diagnosis, or urgent treatments for cancer such as germ cells or small cell carcinomas. The graph here is showing all the inpatient chemotherapy administered in the inpatient setting in the 9 months prior to our implementation. The significant is the proportion of light blue, which represents the outpatient regimens being treated in the inpatient setting. So you can see it's actually quite heavy for outpatient regimens. And also note the increasing outpatient occasions of service with that red line. On further detailed analysis, we were able to determine that 17% of those outpatient regimens could have actually been treated in the outpatient setting. So that was 40 patients in total. We attended a literature search just to identify what the patient preference was, and it came across that there was a preference for outpatient-based treatment in the literature. We completed a discrete choice questionnaire at the Wollongong Hospital to elucidate this patient preference. The survey consisted of patients who'd experienced treatment in both the inpatient, or both settings, the inpatient setting only and the outpatient setting, and the outcome was quite significant with the preference for outpatient location for treatment. The pie graph you see there shows the results for the local questionnaire. So 72% of patients preferred to become treated in the outpatient setting completely, and then there was 12.5% of patients were comfortable with the option of just receiving cycle 1. So on that continuum, it calculates that nearly 84% of patients, or just over, would prefer to end up with outpatient-based treatment in the long run. And this contributes to a statement by Western Australian Health. Indeed, outpatient treatment has been shown to contribute to less disruption of activities of patients' daily living, limit loss of function, and reduce the risk of hospital-acquired infections. The Oncology Information System enabled the organisation of service-wide chemotherapy referrals so that patient care could be provided in the appropriate location. Added functionality provided the ability to centralise referrals, provided detailed patient information greater than that previously provided on paper, and enabled the service to triage and manage patient pathways in real time from multiple locations. If you're in this room earlier this morning, our service manager, Anthony Arnold, presented on, I think the title was Oncology Information System Web-Based Access Portal Development. It was about the Citrix Gateway, and it allows remote access for our health professionals, and that emphasises how we can actually use this from multiple locations as well. The first picture here is of the home screen. This houses all the admission referrals for both the inpatient and outpatient settings. You've got the details of the admission. There's also the ability to add information as you triage the patient, and that is in real time. So as you add something, everyone is able to view that and advocate for the patient. You can also have the ability to investigate the conditions of the referral with the patient chart. It provides layers of information, including the diagnosis, documents, allergies, progress notes, and check on the patient's further schedule. And this one is the clinician worksheet, which is the prescription. You can also see that there's a diagnosis there as well. Additional information, you might get the vital signs as are last recorded, the most recent blood pathologies. So from here, you're able to capture the entire background and plan for the patient from this platform. So once the barriers to referrals were identified, the patient's preference for location was recognised. A small team was established. The objective of avoiding patient chemotherapy admissions by utilising vacant outpatient resources. The team comprised of staff regularly performing system management with key roles in appointment coordination. And the core function was to create a process of monitoring and advocating for clinically relevant transfers of care to outpatients. Patients were scheduled then into vacant outpatient resources as the treatment space arose, thus avoiding the planned inpatient admission. The graph here is a comparison of patients treated with outpatient chemotherapy regimens in the inpatient setting. In the graph to the left is the 9 months prior to implementation. There was a total of 235 patients were treated with outpatient regimens, so that's just the light blue portion on top. And in the 9 months post-implementation to the right, there was only 166 patients treated with outpatient regimens. So that's a reduction of 30%, which is quite significant. The project was able to measure a total of 89 bed days saved by avoidance of admission, resulting in increased bed capacity for the inpatient unit. There was a drug cost saving also calculated for the hospital, $35,000 for the 9 months following the changes. And these were real dollar savings as contributed to the federal government would then pay for the medications in the outpatient setting. But this is not a saving for us as we were calculating, but mainly for the patients. We're putting that money back into their care to be used more appropriately and more efficiently. And as Jerry Marr said this morning, it's reducing the waste in our service. So overall, the chemotherapy treatment in the inpatient setting reduced following these implemented changes. This graph here is the 9 months after the implementation of the Oncology Information System. The dark blue, you can see, demonstrates the inpatient protocols, and they're still reasonably consistent. The light blue shows the decreasing outpatient treatments delivered in the inpatient setting. So there was this graph previously, the light blue portions were much more significant, so it reflects that 30% decrease. But note again the outpatient occasions of service. So that red line, there's a much sharper gradient on it this time, indicating that the outpatient occasions of service actually increased. Historically, that would have affected the inpatient admissions, but you can see here the admissions have actually reduced. The outpatient occasions of service have increased, so it's just demonstrating that we've sent the patients to the right location. And implications. Okay. Specific to local performance indicators, the project achieved significant results in terms of creating capacity. In total, there were 39 admissions avoided, 89 bed days saved, which was an average of 11.1 bed days saving per month. This is just for your interest. Just shows you the drugs where the money was saved in terms of the drugs, and rituximab monoclonal antibodies comprise the highest percentage of those drug cost savings. The project manager, clinical lead and relevant unit managers maintain these recently developed patient management procedures on a daily basis, and these processes are led and owned by the clinical staff. Patient admission information is available to all cancer services nursing staff via the home screen, and that enables the real-time communication between our departments. The visible involvement of key stakeholders and standing agenda on multiple department meetings results in the continual evolution and improvement of the system. Continuing to redesign models of clinical care in the right setting to ensure the patient's journey provides a good experience, good access to care, safe care and efficient service. And that's what we've been able to achieve. Patient engagement, service-wide collaboration and a unique IT utilisation have produced this integrated system with the provision of timely care in the most appropriate setting and delivering the best possible health outcomes for our patients. Thank you.